And to continue on the right track, we need to be thinking not just about the next weeks, but about the next months. We need medium-term and long-term solutions. On that front, I can announce today that we're taking another step forward. We're putting in place an additional $1.1 billion for a national medical and research strategy to address COVID-19.
That money will be invested in 3 different areas. First, $150 million will go towards researching a vaccine for COVID-19. Another $662 million is for clinical trials when a vaccine is ready to be tested. And the third pillar of this investment is for the immediate fight against COVID-19. $350 million will be spent to ramp up testing and modeling. That includes the creation of an immunity task force. Members of it will look at blood tests known as serology testing. Over 2 years, 1 million Canadians will be tested to help answer top-of-mind questions like whether you're immune once you've had COVID-19, and if so, how long does that immunity last? Dr. David Naylor is one of the doctors heading up that group. Dr. Naylor is a professor of medicine and president emeritus at University of Toronto, and he joins us now. Hi, Dr. Naylor. Great pleasure to have you with us.
Hey, Vashi. Nice to be on.
Can I start off just by asking about this task force? It sounds very Star Trek-like. We were all sort of on the edge of our seat, I think, thinking about testing and how it will unfold. How will this task force factor into that? What exactly will you be doing?
So this task force addresses the hidden part of the iceberg, as it were, of COVID-19. If you think about this bug, it's been very unusual in that large numbers of people appear to get the illness and are identified by swabs, the nasopharyngeal swabs. And that's the tip of the iceberg we see. Some 40,000 Canadians have been identified. But there appear to be many more than that who have the infection with very mild symptoms or no symptoms at all. And that's important to understand. It's amazing how little we've learned about this virus, and then understandable perhaps because it's only been with us for 3 or 4 months as a human disease. So if we get to understand just the rest of the illness and its prevalence, that means we have to test not just for people who have the virus today, but people who had it a couple of weeks ago or 3 weeks ago. The only way to pick that up is by testing them for antibodies against the virus. That's the serology, the testing to look for signs of immunity against the virus. Very important to understand the course of the epidemic ahead. Also helps to think about vaccination, who's vulnerable. Will help with identifying some of the individuals on the front lines, like healthcare workers, to see if they're protected. And of course, there are populations like children, where we're still learning just how prevalent the virus might be in kids, because they seem to have very few symptoms at all.
So how will, pardon me, go ahead.
No, lots to learn.
On that, how will the learning, I guess, unfold, is what I'm wondering. We were told 1 million tests over 2 years. How will who gets tested be chosen, and what happens with the results? Will the task force analyze those as well?
Thank you very much. That's a key question. So obviously, we have to start by getting a sense of just how many people have been infected in the past and what the background immunity is. That's important strategically. So probably out of the gate, we'll have to do some testing across the country, smaller samples than we'd like, but to just get some estimation of how many people have had this disease that we didn't know about. And that'll help us plan. Beyond that, however, we are going to have to start to take deeper dives looking at the vulnerable populations, at seniors, long-term care residences, Indigenous communities. We have to figure out whether rural and northern communities, as we would expect, have less immunity than some of the big cities where COVID-19 has really taken a large toll. So there's lots to learn, and we'll sort of start with a few sweeping analyses, sampling widely, and then deeper dives. The other thing I think I have to emphasize, Vashi, is that we need to understand more about what the tests mean. There are a lot of assumptions being made about immunity passports and certification, as if antibodies are immediate, permanent, and total immunity. And we really don't know that. We suspect they protect you, but it would be very important to figure out just how well and how long that protection lasts. So we'll have to follow people over time, and we'll have to get some laboratory research done to figure out how exactly we fight off this virus and why some populations and some people seem to be more effective at fighting it off than others. So lots to learn, important to guide how we manage the epidemic, and we hope eventually clarity that will allow individuals to make decisions. But the first steps really are to guide policy. As we get more certainty, we may be able to say to someone, well, you have a very good chance of being immune to this virus for a very long time. That's where we hope to get, but we're not there yet. We've got a lot of digging to do to get there.
On the question of immunity, Dr. Naylor, when you do show the presence of these antibodies, and I think you mentioned this, but I just want to make sure I understand it in layman's terms, is it that it's not a guarantee that you are immune?
That's correct, Vashi. The general view would be based on past experience, and with many other viruses, that you are likely to be protected. If you are reinfected, you are likely to have a milder form of the illness. That's the experience. And we certainly expect that to be true here. But to say to someone, well, go back to your public-facing job, put yourself in harm's way as a frontline healthcare worker, and to say, and by the way, we think you're okay, that's not really safe advice. We'd like to have a high degree of certainty about just how much protection is afforded and how long it lasts. That's vital here. So I think we're all optimistic that antibodies mean something. I think we all believe that they signal protection, but we need to go from belief to a high degree of certainty and conviction, given the stakes here at the individual level. At a population level, to be clear, knowing that we have wide background immunity is important in its own right. And we don't need exact numbers. We can have a little wobble in those numbers. But for the person making a decision about their own choices in the workplace and their own safety, we'd like to give them a little better advice than broad averages.
On the subject of certainty, with respect to these serological tests, I noticed that they are under sort of a process right now with Health Canada to determine whether they'll be approved. The FDA in the United States has already approved them, but we are seeing the emergence of some stories there where the efficacy, the effectiveness, the accuracy of those tests is somewhat being questioned. What is your level of certainty, I guess, where those tests are concerned, and are you worried at all about their accuracy?
So just to say, the FDA, somewhat frustratingly, took the position that in the COVID-19 emergency situation, it would let a lot of these tests get into the market without full review. And many of them have disclaimers on them saying this is not FDA approved, and yet they're out there being used. So I'm not in the least bit surprised that we're seeing some problems emerge with false positives and mostly false negatives. So Health Canada is looking at this very carefully. The National Microbiology Lab is setting up samples so we can standardize testing across the country. So as the consortium gets going, we can have a distributed set of laboratories that will get it right. The general view is that false negatives are much more common than false positives, which is good news. Some of the false positives seem to be other coronaviruses that cross-react. They may even allow some cross-immunity. So good news there that the false positives don't seem to be a big issue. But Health Canada and the National Microbiology Lab are continuing their diligence. We already have the Secretariat operational at McGill, led by Tim Evans, and they're scouring the literature and doing everything they can to figure out which tests will perform well enough for wide use in Canada. And finally, to say, Vashi, there's two things to think about here. One is the sort of standard serology where you draw blood and you look at the plasma for the antibodies. That's a well-proven test. But there's an awful lot of point-of-care kits out there that give you an answer in a much shorter period of time, sometimes purportedly in minutes. Those kits need a really close look because we have a feeling they will get into wide use and they could mislead a lot of people. So I'm pleased that Health Canada, instead of just letting these things fly out there, is taking some time to get it right. I think that's prudent in the circumstances, and we will be using the best possible tests for Canadians in making these assessments.
I know we're right in the thick of everything right now as it's unfolding, Dr. Naylor, but we have been anxious to speak with you just because of your experience during SARS, and particularly your review of the way in which multiple governments handled that outbreak. I'm wondering, when you look back on that experience and you look at how things have unfolded now, is there something in particular that strikes you, a lesson perhaps that we did not learn based on your reporting and your experience, one that perhaps we should have?
Yeah, it's very easy for anyone to look around and pinpoint some of the missteps, and in many ways I'm glad it's happening, but I've been reluctant to be a sort of armchair quarterback here. I guess the one that I find it impossible to not pinpoint is long-term care and seniors residences. In every outbreak, particularly a respiratory outbreak, those are, potential bonfires. They're just waiting to go up in flames. And the toll taken is really tragic. And these are, as the Prime Minister said, parents and grandparents. There are also some younger people in those homes who were exposed. And I think that one thing that we missed out on was figuring out how to protect some of these vulnerable populations. That's a miss. Beyond that, I think it's important to emphasize there's a lot of differences between this virus, SARS-2 as it were, and SARS-1. This is a more infective organism. It's a little less lethal, but it's certainly taking a huge toll because it's affected so many more people. It has this sneaky habit of lingering along in a lot of asymptomatic and minimally symptomatic people, which confuses the picture. And because it's new in humans, we're struggling to figure out how to treat it, and of course to develop a vaccine. So, I could go through a laundry list of missteps by the WHO, by the Chinese, by the federal government, by the provincial government. There'll be lots of time to do that. But right now, I think the area of acute focus for everybody has to be those homes, the long-term care facilities, and the seniors. That's a big miss, and it has to be remedied quickly. It's unacceptable, as the Prime Minister said.
One quick follow-up, sir, on that, just because I do have you with me. You mentioned the WHO, and there has been a lot of, and I understand that the time for scrutiny it will certainly, be around the corner. But on those questions about the WHO and China, do you think there was too much deference too early on to the Chinese data and information coming from there?
Yeah, sorry to say it, but I think though the WHO has made a lot of reasonable decisions here, given incomplete information, I think they were a little too deferential. They knew from SARS-1 that there had been problems with incomplete reporting. I don't think we lost a huge amount of time, frankly, when you do the time charts and you look at Wuhan and the spread, the Chinese New Year. I don't think that this was a massive amount of time lost. People who say that it was dispositive, that it completely changed the course of the outbreak, are simply wrong. But I think we lost 2 to 3 weeks, and I think that's regrettable, and I think that will come to light when a review is done. The questions are going to be asked of all of us about what we could have done better, but that is one that I would say has to be taken into account, and I suspect the WHO would agree when the dust settles that it should have acted faster and had a higher index of suspicion about what was going on.
Does that mean that Canada needs to re-examine its relationship with the WHO going forward?
I don't think so. I think it's important in this era, above all of global pandemics, that these multilateral organizations are, on the one hand, held to account because we support them with our tax dollars and they're integral to our protection. But on the other hand, that we continue to support them and make them better rather than abandon them or withdraw money from them. They're simply too important to not be held to high standards, but also to be supported and be a source of multilateral collaboration that protects us all. So engage, scrutinize, hold accountable, but support and make better.
Okay, I'll leave it there. Dr. Naylor, thanks for letting us steal so much of your time. I know how busy you are. I very much appreciate it.
My pleasure, Vashti. Thank you so much.
Hi, I'm Vashti Capellos, host of Power in Politics. See more of our show by subscribing to the CBC News channel or click the link for another video.